Welcome to the deep dive. We're always looking at how AI is, pushing boundaries. And, healthcare is definitely one of the most critical areas.
Absolutely.
But actually getting AI to work effectively in, say, a busy hospital ward, these really complex environments, has proven to be a huge challenge. I mean, consider this. Diagnostic errors, just in U.S. hospitals, they contribute to a really, truly alarming number of deaths every year. It just shows there's a massive need for, better tools to help clinicians make decisions.
That's exactly right. And, while these large language models, LLMs, they've shown they can grasp medical knowledge, even past tough medical exams.
Right.
Their actual performance inside the dynamic, information-heavy world of real inpatient care. That's been largely untested. We've kind of been missing the right data to test them properly and, frankly, the right frameworks to guide them in these really high-stakes situations.
Which is why this paper we're digging into today is I think, so important. It hits exactly those points. Yeah. It identifies where current LLMs kind of fall short when you're dealing with complex inpatient treatments, and then it proposes this really novel solution. So if you're interested in the absolute cutting edge of machine learning in medicine, specifically how AI can genuinely support decisions in hospitals, then this deep dive is definitely for you. We're going to break down the problems and look at this promising new approach.
Okay, let's jump right in. So this paper, it basically makes a key two-part contribution here. First, it brings in a new benchmark, specifically for this problem, the Inpatient Pathway Decision Support, or IPDS. Think of it like a really tough new obstacle course for AI in this specific area.
Okay, a new test.
Exactly. And second, it presents a new way of structuring the AI, a framework they call Multi-Agent Inpatient Pathways, or MAP. The main goal here is, to seriously improve how well LLMs can help with those crucial inpatient decisions, like where does the patient go first? That's triage. What's actually wrong? Diagnosis. And then what's the best treatment plan?
Right, the core clinical pathway.
Precisely.
Yeah.
And the really interesting part, the results, they show a pretty significant boost in diagnostic accuracy using this MAP approach compared to even the top LLMs we have right now.
Okay, let's start with that benchmark then, the IPDS. Where did they even get the data for this, and what makes it better or more relevant than what we had before?
Right, so the IPDS benchmark, it was built very carefully using a massive amount of de-identified electronic health records. The data comes from the MIMCV database.
Oh yeah, MIMC is pretty well known.
It is. It's a public resource, tons of detailed patient data from a big medical center. And the researchers pulled info from different bits of MIMC. They mean hospital records, ICU data, clinical notes, all of it.
So really comprehensive.
Absolutely. We're talking over 51,000 patient cases. It covers 9 different hospital departments, 17 major disease categories, 16 standard treatment options. And the data itself includes, demographics, those vital radiology reports, patient's medical history, all the rich, messy stuff doctors look at daily.
That sounds way more complex and, real world. So what was wrong with the older benchmarks? Why did they need to build this new one?
That's a really key question. A lot of the previous benchmarks for medical AI, they often focus more on answering multiple choice questions from medical exams.
Ah, okay. Like testing book knowledge.
Exactly, or just general medical knowledge queries. One big limitation was they often didn't cover enough different hospital departments, which could, skew the results. There was also this worry about data leakage, maybe benchmark questions accidentally overlapped with stuff the models already saw online, like medical forums or textbooks.
Right.
But maybe the biggest issue, testing knowledge with multiple choice questions just doesn't capture this sort of open-ended, nuanced process of making an actual diagnosis in a hospital, where a doctor has to pull together lots of different pieces of information.
Makes sense. It's not just picking A, B, C, or D.
Not at all. So IPDS is designed specifically to mirror those complex, real-world inpatient situations much more closely.
Okay, so a much better test track. Now let's get into the MAP framework itself. You said it's not just one AI model, but a team of them.
Exactly. MAP is built around this idea of specialized AI agents working together, a bit like how different specialists collaborate in a hospital.
Interesting.
So you have 3 main clinician agents. There's a triage agent, handles the initial assessment, figures out which department the patient needs. Then a diagnosis agent. This one's the main decision maker within a department, figuring out the condition. And finally, a treatment agent suggesting the right plan based on that diagnosis.
Okay, triage, diagnosis, treatment. Makes sense.
And then overseeing all of them is a chief agent. Think of it like the attending physician providing a higher level view, offering guidance, making sure everything's coordinated for the patient's whole journey through the hospital.
That's a fascinating architecture. It really does mirror a human team. How do these different AI agents actually, talk to each other? How does it work?
They use a structured communication protocol. It includes the context, what tasks they're working on, then their thinking process, basically, showing their work, how they got to their conclusion. And finally, the answer, often using standard medical terms, ICD-10 codes, that sort of thing.
So it's quite transparent.
Yeah, that structured communication helps make their interactions clearer, which is obviously really important if you're thinking about using this in a real clinic. And the MAP framework also has these 3 key technical pieces, these modules, that really boost their performance.
Okay, let's break those down. What are these core innovations that make MP work so well?
Okay, the first key module is something they call record review. This uses semantic analysis powered by a model called ClinicalBERT.
ClinicalBERT, right. Trained on medical text.
Exactly. So it really understands the meaning behind medical terms. It figures out how different parts of a patient's history relate to what's happening now, like the findings in a radiology report. It essentially helps filter out the noise stuff that's less relevant or maybe even contradicts the main picture.
So like if the x-ray shows a lung issue, it knows to focus on that, not the ankle sprain from 10 years ago.
Precisely. It helps the diagnosis agent focus on the most important data points. It's about finding the relevant pieces of the puzzle in that big patient record.
Yeah, okay, that makes a lot of sense. What's the second piece that helps MAP?
The second module is the Trainable Retrieval-Enhanced Generation module, or RAG for short. This is where the diagnosis agent does its really deep thinking. It uses a tool called LAMA Index.
LAMA Index, yeah, I've heard of that, like a smart retrieval system.
Kind of like a super efficient research assistant for the AI. It quickly finds and pulls relevant medical info from huge databases. In this case, they use the NICE guidelines, which are widely used clinical practice guidelines.
Okay.
Then the AI combines that retrieved knowledge with the patient's specific details, and it uses a technique called chain of thought reasoning to arrive at the diagnosis.
Chain of thought, so it lays out its reasoning steps.
Exactly. Think of it like a good doctor reviewing the latest research and best practices before making a call for this specific patient. So it's not just using its pre-trained knowledge, it's actively fetching the most current relevant info for each case.
Right, so it's augmenting its knowledge on the fly. Very clever. And the third critical module?
The third one is expert guidance. This is where that chief agent really comes into play, especially during the AI's training phase.
So it's like a teacher.
Pretty much. The chief agent acts like a supervising physician. It gives feedback to the other agents, triage, diagnosis, treatment based on its broader medical knowledge. It can spot errors in their logic, point out inconsistencies, guide them towards better conclusions.
I see.
This whole feedback loop helps the individual clinician agents learn and get better over time. It's like having a senior doctor reviewing a junior resident's reasoning and giving pointers.
That sounds like a really robust training approach. So, okay, you've got this multi-agent NAP framework with record review, REG, expert guidance. How did it actually do on that tough IPDS benchmark compared to the standard LLMs?
Well, the results were quite striking. The researchers tested several top LMs, LME-3, internal LM2, even medical-specific ones like Wattu GPT-2 and Metatron.
Right.
And what they found was these standard models really struggled on IPDS. Their diagnostic accuracy was often below 53%.
Wow, okay. That's not great for such complex tasks.
Not ideal, no. But the MAP framework, it hit 78.10% accuracy on diagnosis. That's a massive jump, over 25% better than the best standard LLM they tested, Wattu GPT-2. It really shows the power of this specialized multi-agent design.
That is a really significant leap. Did that improvement hold up across all different kinds of medical conditions, or were there specific areas where it's shown?
Interestingly, yeah, MAP did particularly well with more complex, nuanced cases, things like mental and behavioral disorders, areas where standard LLMs often have a tough time. And they also did these ablation studies, which basically means they took out each key module one by one, the record review, the REG, the expert guidance, to see how much each one contributed.
To see which parts were doing the heavy lifting.
Exactly. And those studies clearly showed that each of those modules was playing a really significant part in getting that high accuracy. They all mattered.
And now for maybe the most surprising part for some people. How did MAP stack up against actual human doctors in this study?
This is where it gets really interesting. So they took 100 random cases from the IPS test set and had 3 independent board-certified physicians diagnose them.
Okay, real clinicians.
Real clinicians, and the MAP framework actually outperformed them. Its diagnostic accuracy was about 10% to 12% higher than the human doctors.
Wow, seriously, 10-12% higher.
Seriously. And furthermore, statistical analysis showed that MAP's diagnoses agreed very strongly with the actual correct diagnoses in the data set, the ground truth. That agreement level, measured by something called ICC, was even higher than the agreement level between the individual human clinicians themselves.
That is pretty striking.
Okay.
But it wasn't perfect, right? Were there still types of cases where MAP struggled or where misdiagnoses happened more often?
Oh, absolutely, yeah. They looked into the misdiagnosis rates. Certain categories were still tougher for MAP, things like general symptoms that don't easily fit one box, certain infectious diseases, some skin conditions.
Okay, so still room for improvement.
Definitely. But what was interesting was that MAP's errors were kind of more evenly spread out across different disease types. The human clinicians' errors tended to cluster more in specific areas, and they also confirmed something pretty crucial. Having access to the detailed medical history and the radiology reports was really important for accuracy. Adding that information led to big improvements for certain diseases. Demographics helped a bit, but history and imaging were key.
Got it. So pulling this all together, what's the really core significance here? What makes this research stand out in the field of AI in healthcare?
I think the core significance is that it really tackles this critical but honestly underexplored area, applying AI effectively within the messy reality of inpatient hospital care.
Right, moving beyond the theoretical.
Exactly. So the paper gives us 2 big things. First, this new, much more realistic benchmark, IPDS, to actually measure progress. Second, this innovative MAP framework, a multi-agent approach that goes way beyond just using a single generic LLM.
And it works better.
And it works demonstrably better than state-of-the-art LLMs, and even on this benchmark, better than experienced clinicians. That's a major finding. It really underlines the potential for these collaborative, specialized AI systems, and it highlights just how vital it is to integrate patient data properly and build sophisticated reasoning into these clinical AI tools.
Yeah.
Oh, and the fact that they've made both IPDS and MAP publicly available, that's huge for future research. It lets other people build on this work.
Absolutely. That's fantastic for the community. This really does feel like a significant step forward in figuring out how ML can actually be useful in hospitals. Okay, now, as we look to do here on the deep dive, let's shift gears a bit into our novel notions segment. Time to get a bit speculative.
Yeah.
Based on this paper, what sort of future research directions, maybe even slightly out there ideas, come to mind?
Okay, yeah. Building on MAP, one really fascinating direction could be developing personalized inpatient pathways with real-time adaptation.
Ooh, okay. Real-time adaptation. What does that mean?
Well, imagine if a system like MAP didn't just follow a static plan, but could continuously learn from how a patient is actually doing during their hospital stay.
So using live data.
Exactly. Integrate real-time data streams, constant vital signs, new lab results as they pop up, maybe even notes from nurses or therapists. The AI agents could then dynamically adjust their assessments, refine the diagnosis, update treatment recommendations based on what's happening right now.
That sounds incredibly powerful, almost like the AI is constantly monitoring and adjusting the plan. What's the really extreme possibility there? Where could that lead?
The extreme possibility. Maybe truly personalized care plans that could actually anticipate complications before they fully develop.
Wow. Predicting problems.
Potentially. By analyzing all that incoming data, the AI might spot subtle patterns, predict negative turns, and flag them for proactive intervention. This could, optimize how hospital resources are used, maybe shorten stays, and ultimately lead to significantly better patient outcomes than our current, more standardized pathways.
And how does that idea connect with wider trends we're seeing in AI in healthcare?
Well, it perfectly blends this multi-agent system idea, which MAP demonstrates, with the huge growth in continuous learning AI techniques, and of course, the explosion of real-time health data from monitors and wearables.
Right.
MAP shows strong initial diagnostic skill. The next step could be integrating continuous learning methods, maybe reinforcement learning, things like that to let the agents adapt. And we are getting more and more real-time data these days.
Are there potential downsides or tricky implications we need to think about with a system that's constantly changing the plan?
Oh, absolutely. Big ones. First, reliability and safety. How do you rigorously prove that the AI's adaptations are actually helping and not introducing new risks? That's crucial.
Yeah, validation would be key.
Totally. And then there's explainability. Clinicians need to understand why the AI is suggesting a change as the patient's condition shifts. You have to maintain trust. Oversight is non-negotiable.
So realistically, how likely is it we'll see this kind of real-time adaptive system anytime soon?
I think maybe. Initial versions focused on monitoring and flagging potential issues. Hey, this patient might be deviating from the expected path. Maybe take a closer look. That seems plausible maybe in the next few years. High probability for that sort of advisory role.
But not fully autonomous changes.
Fully autonomous dynamic adaptation of core treatments, where the AI changes major things without direct sign-off, that's likely much further out. The safety critical nature, the validation needed, regulatory hurdles, that makes it a longer-term prospect, lower probability short-term.
Makes sense, a cautious evolution. Okay, what's another novel notion sparked by this MAP paper?
My second idea dives into using federated learning to train these inpatient pathway models across lots of different healthcare systems.
Federated learning. So training without sharing the raw data.
Exactly. Remember, the IPDS benchmark, while great, used data from just one hospital system. What if we could train MAP or similar systems using data from many hospitals with different patient groups, different common diseases, maybe even different ways of recording data?
Without pooling all that sensitive patient data in one place.
Precisely. Federated learning lets you do that. Train the model locally at each hospital, and then aggregate the learned model updates, not the data itself.
That sounds like it could solve major privacy issues and maybe make the models better. What's the ultimate upside there?
The ultimate potential is creating AI models for inpatient care that are much more generalizable and robust, less biased towards one hospital's specific population or practices.
It's fairer and more effective globally.
Potentially, yes.
Yeah.
Models trained this way could offer better, more equitable recommendations to a much wider range of patients, no matter where they happen to get treated.
And how does this fit with current AI trends? Is federated learning catching on in medicine?
Oh, definitely. It's a huge trend, driven by the need for privacy-preserving AI in healthcare. We're already seeing it used successfully in things like medical imaging analysis. The challenge here would be adapting it for the complexity of electronic health records. It's not just images, it's text, numbers, time series data, all interconnected. More complex than, say, just training on X-rays.
Right. So what are the specific hurdles? What makes federated learning tricky for this kind of inpatient pathway data?
Well, a big one is data heterogeneity. Different hospitals record things differently, use different coding systems, maybe follow slightly different protocols. How do you make sure the model learns effectively and fairly from all that variation? That's tough.
Yeah, standardizing seems hard.
Very. And then how do you evaluate the final federated model? You don't have one central test set. You also need robust data governance agreements between all the participating hospitals, secure communication. It gets complicated fast.
Lots of logistical and technical challenges. So what's your gut feeling on the probability here? Will we see widespread federated learning for these models?
I think we'll likely see more research and pilot studies trying federated learning for specific inpatient tasks like predicting readmissions or identifying high-risk patients. Medium probability for seeing progress there in the next, say, 3 to 5 years.
So maybe not for the whole pathway.
Large-scale deployment across diverse hospital networks for comprehensive pathway support, that feels like a longer-term goal. Lower probability in the near term, just given all those technical and governance hurdles we mentioned.
Still, fascinating possibilities to think about. It really shows how this one paper could spark so many different complex lines of future work.
Indeed. And just a quick disclaimer, of course, these novel notions are purely speculative, just for discussion.
Absolutely, food for thought.
Yeah.
So to quickly wrap up our deep dive today, we looked at IPDS, a new, more realistic way to test AI in hospitals. And we explored the MAP framework, this multi-agent system, showing really impressive results in boosting clinical decision accuracy even, potentially outperforming human docs on some tasks.
And I think this work really underscores how ML is moving beyond just, crunching data towards actively supporting and maybe even enhancing these really complex clinical workflows.
It really does. It makes you wonder, doesn't it? How could these AI advancements fundamentally change the day-to-day roles of doctors and nurses and the whole way hospital care is delivered? What does that AI clinician collaboration look like down the road? It's a pretty profound question to ponder.
Absolutely is.
Well, for those of you listening who want to get into the nitty-gritty of the IPDS benchmark and the MAP framework, we've put a link to the actual research paper in the description for this deep dive. As always, thanks so much for joining us.
Thanks, everyone.
And we look forward to exploring another fascinating topic with you next time on the Deep Dive.